So, a very good morning to all of you, and we would like to start this STAAR Symposia, and along with me, Dr. G.S. Tatyal and Dr. Radhika Tandon would be chairing the session, and I have with me my co-moderator, Dr. Thomas. Welcome, Dr. Thomas, to India and the AIOS, Delhi, and Dr. Namrata Sharma, Dr. Partha Biswas, and Dr. Vardhaman Kankaria. Welcome, Vardhaman. And Dr. Bharti, welcome, sir, as the panel for this session. So without wasting much time, I would like to invite none other than the doyen of ophthalmology, Indian ophthalmology, Dr. Mahipal Sachdev, who is the managing director of the Center for Sight Group of Eye Hospitals, and he'll be talking on his experience of Collamer technology, 30 years of Collamer technology, delivering superior patient outcomes. All to you, sir.
So, thank you very much, Sonu, for the kind words. It's a pleasure being here. Dr. Karan, Sonu, Vardhaman, Dr. Bharti. Well, I'll be just talking about as an overview of 30 years of Collamer technology, just to bring home to you that this particular technology has been around for 30 years. And I've had the fortune, or I would say it's been fortunate for me that I've been using it for about 25 years, started in 1999. Obviously, the numbers were low, but let's look at the evolution. The first implants globally were done in 1993. At that time, I still remember there were two implants. One was the ICL and the second was the PRL. I think PRL was by a company called SIBA. And that went into disrepute, and the project was aborted because it would cut through the zonules, and there were 6, 7, 8 reports of the lens falling into the vitreous. But this lens has stood the test of time, and it received the CE mark for spherical ICL both for hyperopia and myopia in 1997. At that particular time, the changes were not there. You didn't have the V4 model, so doing a peripheral iridotomy was mandatory, whether it was myopic or hyperopic, which is there. US FDA approved it in 2005, and then went on for, say, the Vision. The V4 model then came in. Then you have the extended optics. So there is the new model which has a larger optic. And then you have the Viva, which has been launched in 2020. I have implanted some, which is the one which is the EDOF, or the lens which is also presbyopia correcting. So this has been the journey so far, the various landmarks for this particular lens which has been there. Just to show you that it's a simple lens material made of Collamer. There is no other company that is making with the similar material. So the lens has stood the test of time for biocompatibility. Within our circle, have not seen anybody saying that because of biocompatibility or recurrent reactions, etc., the lens needed to have been explanted. So therefore, it has stood the test of time. So this is a simple injector system that you do, and you can push it, and you can, the only thing is when you are pushing in the lens, you have to go parallel to the iris, and not like when you're putting an intraocular lens, you don't push it towards the optic nerve, and then you can dial it. I'll just show you in the next one. Nowadays, with the easy availability of phenocaine, you can go ahead just maybe for one odd remote case to protect the lens, not dilate the pupil. The patient can come, and you can just go ahead and put the phenocaine, as you can see. Because they are young individuals, they are not on something like, they are not diabetics, they are not normally on tamsulosin or anything. So you can achieve the same, the pupil dilatation on the table that you have. And you can go ahead and then with a fully dilated pupil at that particular time, you can go ahead and push in the lens, as you can see. So lens, as I was saying, you don't need to push it below the iris, because that way you could damage the normal crystalline lens. You want the lens to open softly, gently. I normally have the nozzle push. I don't want to make the incision as part of the injecting system. I would rather take the nozzle inside, because this prevents upside down unfolding of the lens. So now you can see that you have this plate haptic lens within the anterior chamber, and then you don't go over the optic, because the optic is reasonably thin. So you just go by the side of it and push in the 4 haptics into the proper place, and then you can align the lens. If it is a toric, you can see these are the marks which are there, so you align it. Now, you can use the intra-op OCT to check on the vault. So you can see that this is the vault that you can check on the intra-op OCT to see whether the lens has a proper vault or not. So it can help you by not leaving a big or a large or a small vault which is there. Now, the material obviously matters, though there are a couple of lenses that are available. I don't know globally, but at least in India, there are 3 other companies who are manufacturing these lenses, but none of them have the polymer material. They are either the same material that was being used for the IOLs, or there may be some changes in the water content, etc. But basically, it's a hydrophilic material that they're using. So the polymer is actually collagen and a copolymer which is there. It does have a little bit of a porcine content in it. The polymer is an inert material and it offers UV protection and is one of the most biocompatible materials that are available. There is no inflammation, flare or cellular reaction that you see. Now, this is a study that has been done, 20 years of polymer in patient eyes, and what was found was that it was 1993 ICL was stable, biocompatible. A patient had developed the cataract, and if you see, there is nothing like a glistening or anything or any other thing that has happened post removal of the ICL. So no synechia, no bleeding. So the lens explantation was easy even after more than 20 years or 25 years of the lens in. Now this is the new design that you have. These are the various designs. So you have the larger optic zone and the smaller optic zone. So there are these holes, and this is the central 300 micron hole. You have 2 full thickness holes. So you have this now in hyperopic variety also. You have this with the larger optic, the toric variety and the non-toric variety. And you have the Viva also, which is there. The biggest breakthrough that came was to obviate the need of doing a peripheral iridotomy, and that was because there was a 300 micron hole that was there. We were all very apprehensive about it, that how is it going to affect the patient's vision at night time, etc., etc. But by far, we have seen, yes, the patients do complain to begin with, but it settles down in a couple of weeks and they no longer complain about it. And this obviously removes one extra step of doing a peripheral iridotomy, which is there. So this is how the lens lies, and this is how it stays there. Now, let us look at the safety, effectiveness, and the outcomes. What is the literature that is to say on this? And you can see these are the number of peer-reviewed publications which are there. So you can see in these cases, these are only from 2018 onwards. So you can see that this is reaching 6.6, and you can see that the safety index is very high. You can see that the efficacy index is very high. So it's 1 is supposed to be the best. So that is what you are looking at. If you are looking at the other data that is there with the central port, this is from 67 preclinical and clinical reports through October 2018. So you can see that these are the number of papers which have been published across. So there is a lot of data that is available, and there are lots and lots of surgeons who are using this. I don't know the number of surgeons, but the biggest advantage in the ICL is that you can use it even if you don't have a laser vision correction machine with you. You just need to be doing your cataracts, and the same things can be used. Now this you can see is the historical safety concerns, 147 eyes, 57, etc., Kamaya, Lisa, Simuzu, etc. So you can see follow-up of 1 to 5 years. This is to look at the endothelial cell loss. So if you look at the endothelial cell loss, there is very little endothelial cell loss. If you have done an atraumatic insertion of the lens and then post-op, there is almost equivalent to the normal cell loss that any person will have. So the central port and its ability to facilitate the flow of aqueous through the ICL has provided the safety to the procedure and helps minimize the potential risk associated with the low vault, because still there is a space and you have fluid, so low vault problem is not there. Now this is a new refractive surgery paradigm that is being this thing. So you have a comparison of evotoric, femtosecond LASIK and relax smile, and this is -3 to -8 that has been compared. the matched population comparison of visual outcomes and patient satisfaction between these three modalities, that is the KLEX, the LASIK and the ICL, all three groups were comparable in all parameters, that is UDVA, DCVA, spherical equivalent, etc. But the EVO had the highest safety efficacy, highest safety index, highest efficacy, safety, and no significant change in the endothelial this thing. When you're looking at further, you're looking that the toric ICL has demonstrated that post-operative dry eye was the least. That is as expected because you are doing at the limbus and it's only a 2.8 or a 3 millimeter incision versus a full flap, etc. There is a significant improvement in the higher order abrasions because you are not doing anything. It's an additive procedure. It's not a subtractive procedure. You are not taking away any corneal tissues. So you are not inducing any higher order abrasions, etc. that you induce even while making a flap. You just make a flap, put it back, you would have induced abrasions. So you are not doing anything, and patients reported excellent satisfaction with their quality of vision. Again, if you compare at low to moderate, the point is most of us or most of you sitting here still consider LASIK as the gold standard for low myopia. So there is this comparison that they have done when you are tackling these patients of low myopia. One thing was that you don't want to do a patient more than -8 or -10 with LASIK because you have to take away a lot of tissue. But supposing we were to consider this as the first choice for low myopia, how do we fare? So you can see that the number of side effects is very significant. The author's conclusion in all these is that it works very well in low myopia, and this is in clinical ophthalmology for moderate myopia across a US FDA clinical trial of 200 eyes and 114 patients, -3 to -6 with the average -4.61. And again, if you look at low myopia patients, what is standing out is safety being pretty high. When you look at the effectiveness, it is 94.5% achieved 20/20 or better at 6 months. When you're looking at predictability, it's a very highly predictable, least regression. You don't have regression in it as you can have in laser vision correction. And this is the hallmark, that it is stable, predictable, and stable. So this is what, even for the low myopia, this is the data that is there. So out of these studies, the ICL lenses demonstrated accuracy, as I told you, predictability and stability of the refractive correction with achievement of high levels of UDVA and an excellent safety profile for patients of moderate myopia. Just to again look at these laser vision correction. So this is the data that was there. As you can see here, that 52.3% gained one line. If you look at moderate, it is 56%. Smile was only 20.4. So this wavefront guided was 55. So this is comparable to the wavefront guided, but much better than the other ones. As of now, the patient satisfaction, if you go back and ask the patient after the procedure, what is your satisfaction? Did you do the right thing to get this procedure done, etc.? Even the laser vision correction comes to about 96 to 97%, but here it comes to 99.4%, which is that they feel that they have done the right thing, they got the procedure done. So very high, excellent patient satisfaction. So this is actually, to sum up, to say that EVO is a true surgical option for all eligible myopes. Because of the additive in nature, not a subtractive nature, superb quality of vision, excellent night vision, rapid recovery. There was the problem of night vision, so they have a larger optic lens also, so that issue is there. Low rate of adverse events. I would prefer to have a cataract, an early onset of cataract, and deal with it rather than have an ectasia. So that is the issue, that the adverse effects are low, and even if they are treatable. And it is removable by the surgeon. So that means it's a very powerful thing that you can tell the patient that I can take it out if it doesn't do well. So finally, this is all that I'll wish to say. What are the key takeaways from this? It has a long established history of 30 years of a highly biocompatible material, additive in nature, not subtractive in nature, patient satisfaction 99.4%, no problem in contrast, reversible lens implant, quick procedure and recovery. We still, most of us do it one eye. Dr. Bharti, I know he does both the eyes together. You can do it both the eyes together. That's up to you. I still prefer to do one eye the other day, the next day also to look at the vault, etc. And it does not induce dry eye and also gives UV protection. So friends, this is what I wanted to say as regards the 30 years of experience that is there and what we feel as regards this being a wonderful technology for taking care of myopia and hyperopia, including astigmatism and maybe presbyopia now. Thank you very much for your kind attention.
Mahipal, thank you very much. This was a nice talk, 30 years of experience. We go directly. If there's any questions here in the room?
Sir, if size of the optical zone is increased, then is there any chances of optic capture?
उल्टा बोल रहे, बड़ा होगा तो ऑप्टिक कैप्चर क्यों होगा?
सर ऑप्टिक का साइज बड़ा होएगा
तो
उस
optic
टाइम
capture
पे
क्यों होगा?
सर कैप्चर होने के चांसेस है क्या?
Why? ऑप्टिक बढ़ रहा है ना, ओवरऑल साइज का तो
Do you mean the pupil size?
No. Optical size is increased, sir.
Why should it capture?
Why should? I don't know.
There is a change
The vault
in
is normal, it should not get captured.
No.
We haven't seen any case of capturing.
नहीं capture.
Just a quick question to you, sir. What is the lowest diopter of ICL that you implanted in all these 30 years? I think that speaks of the entire gamut of the myopia that you've been doing.
So I think the lowest I have done is something like -3.
So I think that restores us that it is good for the entire spectrum of myopia. Thank you very much, sir, for your wonderful experience.
I think, Sonu, since the hall is full, that shows that there is lot more interest than when it came in, and it's a very acceptable modality today. So I personally feel that this can be done by any surgeon. The only problem is what I suggest to the STAAR people is that not many people know about it so far. So actually, gold standard LASIK patient comes to you and then you tell him, no, you go for an ICL, so there is some form of a resistance. The patient should actually come asking for an ICL. So that solves a lot of problems.
Mahipal, thank you very much. We go to the next presentation. Dr. Ang from the Philippines will present his paper on the EVO. Thank you.
Good morning. Thank you for having me in this STAAR Symposium. So my talk is about from exception to everybody, my approach to EVO ICL offering. So I'm an investigator for STAAR Surgical as well as other companies. So in my private practice, so we practice in Manila, the Philippines, and we have 2 surgery centers and 5 satellite clinics. And my role there is cataract, refractive, glaucoma, and cornea. And so far, over the past 25 years, I've been doing LASIK, PRK, ICL, and I've had the fortune of participating in these pilot studies of the Viva ICL. So, like others, 20 plus years ago, we bought our excimer laser and we started practicing LASIK and PRK. And we were happy. We learned and accepted the limitations, the outcomes, and the problems associated with LASIK and PRK. We also learned that higher treatments or deeper ablations can cause ectasia, induce aberrations. So better diagnostics over the years helped us detect these suspicious corneas. And another thing that we notice in our practices is more and more kids now come with higher myopia. 20 years ago, it's usually -3, -4. Now, when they come teenagers, they're -7, -8. So higher and higher myopes are coming to our clinic. So just like most of us, our ICL use was, if they're not qualified for LASIK, that's when we offer ICL. So those were beyond the range of LASIK, or they had thin corneas, irregular corneas, insufficient stromal bed. That's why we introduced ICL. It wasn't a first-line offering, but you're not qualified, we have something else. So at that time, our ICL was limited to the highest of myopes. So we put together some of our outcomes, and whether it's LASIK, PRK, or ICL, the MRSEs were very, very good, very similar in terms of efficacy. In terms of UDVA, they were good enough because the high myopes also had good uncorrected distance vision, just like your LASIK and PRKs. So one of the things that we track over time is safety, and safety means two things. Number one is your IOP. You shouldn't get a spike, whether in the immediate or late post-op phase. And we watch the endothelial cell count. So whenever they come once a year, I would do a specular microscopy. And we see that aside from the initial trauma of the first surgery, they were stable. So it gives us good confidence that the lens can stay there basically forever. So spherical aberration-wise, we know that the higher treatments cause induction of positive spherical aberration, whereas if you don't touch the cornea, then more or less you're safe and stable with untouched or basically minimal change in spherical aberration. So early experience with the ICL was in high myopia. They were very good, reliable. And now I can treat somebody from -1 for LASIK PRK all the way till -18 for ICL. But over the past early years, so I started maybe 13, 14 years ago, and I was still careful and selective because number one, you had to do a YAG-LI. So some patients, why are you going to laser me? I thought I was not a candidate for laser because they don't know what's the difference between YAG and LASIK. No? Next is you want to watch for early cataracts because the early papers were quoting cataracts as one of the early side effects. And next is, even though there were publications about ICL sizing and STAAR will help you, you had to kind of figure out yourself because the sizing protocols were mostly Caucasian eyes. I would actually read up on the Japanese publications because they were closer to our Chinese eyes. So we were kind of hedging which method to choose. But then the breakthrough came when the Aquaport was introduced. So when the Aquaport was introduced, number one is it eliminated the need for YAG-LI. So I don't have to explain to them that we had to do YAG-LI before we implant. It became a one-step instead of a two-step procedure. Second is, I believe that because of the cushion of aqueous flow between the natural lens and the phakic IOL, there's a buffer of aqueous that prevents touch. So you eliminated the cataract. So those things made me and others more confident about putting the ICLs. So these are published literatures, just like Mahipal showed, that either the published literature or the FDA trials showed the same thing. The lens gave good refractive accuracy, and the UDVA was very good, and the efficacy index is exceeding 1.0, meaning the uncorrected vision is most of the time better than the pre-op best corrected vision. So in terms of effectiveness, it was good. And safety-wise, very rare. Of course, I also had my own share of uretzevalia, maybe over 3-4 cases over the past 13 years, which is a nightmare, but all of us will see that there's no glaucoma, pupillary block, pigments are not flying around the anterior chamber, and cataract is almost none. So these further increase our confidence in using the ICL long term. Because the parents of the child, the teenager in front of me would always ask, how long can this stay in my child's eye, right? So now we give them figures like some patients had 30 years ago and when they explanted the lens for cataract. So I just tell them, when you get a cataract and need cataract surgery, that's when the lens needs to go. So now, evolution of change, just like EVO, evolution of change, because of certain factors for patient selection, you kind of know that more and more patients can benefit from ICL. So first is the myope, so minus 0.5 to 20 diopters. Then age, because of the Viva, now the indication in the box now goes up to 60 from before it was 45. So if you notice the box, it used to be up to 45, now it's 60. Then we had two things. Number one is the ACD, at least on label now, is 2.8 because in the Philippines, many are 2.6, 2.7, not very deep, no? Very few are above 3. So even though they're myopes, they're not so deep, no? And then corneal status, of course, if they're suspicious now because of the pentacam, because of the SCORE program, the anterior, now we're very sensitive to suspicious topographies. And any type of suspicion, you have a choice. Are you going to do KLEX? Are you going to do PRK? Or are you going to do ICL? So since I don't have KLEX, it's either LASIK or ICL. Those are the options for my patients. So first, before, only the high myopes, -6, -10, came to our clinic. And now, I offer it to even -6 below. So you see that some of my patients are even below -3. So my lowest case is -1. I have had patient who's a -1. And they all have a good criteria. The second thing is the ACD, as I said, now 2.8 or 2.8 is good. Actually, when we speak to the Japanese, they go down to 2.5, but that's off-label. On-label, let's remember 2.8. No? You can use a pentacam, you can use an orb scan, Anterion, whichever one you have, but make sure so we don't get sued. One of them says 2.8 and above, no? Just to be sure. Now, our data shows that similar to all the published studies, 90% are 20/20 uncorrected in our patient base, and refractive accuracy is actually quite good. So it's actually more, I get more confidence with ICL than with the high myopia LASIK. So one thing that is
Can
coming,
I just request, sorry for that interruption, can I just request to summarize because we are running out of time.
okay,
Yeah,
so retreatments are an opportunity. Those that have myopic regression, we offer them ICL instead of LASIK enhancement. And we had these patients, so 10 out of the people that we want for myopic regression, we implanted an ICL. And as you can see, some of them are really below 3 diopters, some are 1 diopter, 2 diopter. So our results show that the MRSE is as good as LASIK and PRK at the end of 6 months, and UDVAs are as good. Now, the complications are also rare. Only Volt is the worry. Lastly is the Viva. So when the Viva, we started the pilot study 7 years ago, it was a concept wherein we give them EDOF concept of an ICL for presbyopia treatment. And we did a study, 90 eyes, with toric and non-toric versions. You see that the MRSE now is on target. So we made adjustments in the nomogram so that this phase was good and stable. Stability, MRSE, and accuracy to target of the Viva and the Viva toric. UDVA was quite good, and CDVA was quite good. So about 20/25 or 20/20 in most patients. Now, UIVA is also very good because it's EDOF. Remember, EDOF is good distance and intermediate. Now, the near vision over time is about 20/30. Don't promise J1 because they're not J1, just like your EDOF. Never promise J1. So, in summary, the ICL usage for me has grown over the years. We started from high myopes, high astigmatism. Now, the low myopes, as I said, up to -1 we use, especially for retreatments, and then we expanded now to the presbyopic age group. So only those with shallow ACD and low spec count will be disqualified. Everything else, you can ask them and offer ICL. Thank you.
Thank you very much for that wonderful talk. And any questions? We can take Dr. Sudhang Bharti. Do you have any comment?
I think the same thing about the low myopes. I also have, wherever there is a question mark topography, I want to. So my lowest implanted ICL is 2.25. So that is the, and it's about a year back that I did, and she's doing fine. So I think we are comfortable doing ICL in a low myope also now.
Yeah. So Vadman, do you want to comment?
Yeah, I think I'll definitely agree with all the discussion. And yesterday only we had a free paper presented by one of our fellows where we presented 361 eyes for people who had moderate and low myopia, ranging between -2 to -6. And we have seen excellent outcomes up to at least 1 year of follow-up, up to 2 years. I'm very sure that I think whatever the benefits and the safety we have seen for the high myopes, of course, that is going to also translate into the moderate myopes. And now we see more and more suspicion of keratoconus because the tools have become better. Because of tomography, we are able to identify keratoconus suspects much better. And that's why I think the threshold is reducing. And definitely it has worked very well in our set of patients. Yeah, thank you.
Thanks, Vardhman. Now I'll invite Professor Thomas. He'll be talking on EVO ICL patient outcomes in moderate myopia. And very interesting, his experience with lens sizing using the Lasso formula. All to you, sir.
Thank you very much. First of all, thanks STAAR for inviting me to this program here, and of course the APAO and the ESURS actually to bring us over here. I'm a consultant for STAAR and for several other companies who produce phakic IOLs over the years. Here's the disclosure. We have talked about all these phakic IOLs is definitely a therapy option for refractive errors, as well as we have the corneal procedures and refractive lens exchange with all the various IOLs. So my experience goes back to more than 3,000 phakic IOLs personally implanted, all types of phakic IOLs from angle supported to iris fixated to posterior chamber length. Actually, posterior chamber was my first in 1999, which was the ICL followed by PRL, and most recently we're doing this. I show you a study which we published in the peer-reviewed literature, 5-year result, as one of my fellows, first author, Krzysztof Lwowski. We actually had a -10 diopter myopia going up to -4.5, so half a diopter at our outcome. The loss with surgery was 1.9 per year. Rare cataract formation, this was 0.8%. This was only 2 eyes in this series. And I think that with the central aqua flow, we have really solved this problem of cataract formation in the ICL. The ESURS guidelines in progress, actually at the moment, you will see them at the Copenhagen meeting. Indications actually go from -1 diopter with an ACD depth of 2.8 millimeters, for hyperopia from 1 diopter with 3 millimeters of ACD depth, astigmatism of starting by half a diopter, and predictability and safety is there higher predictability than LASIK, PRK, KLEX in the high myopic patients above -6 diopter. And it seems safe, but limited evidence regarding predictability, safety of hyperopia and astigmatism. Why I put this here, this is a peer-reviewed literature, and the document is more than 300 pages long, where we really investigated this. Making a personal statement, I correct all astigmatism from half a diopter with the ICL, and approximately I have 70% of toric ICLs which I implant at the moment. And I start basically from all this area down there. This is the German guideline, which is also, you find it in the literature, published in English actually, the ophthalmology. And there, our application area starts from -1 diopter, basically up to the limit where we can go. Hyperopia +1, astigmatism, toric, or ICL, as I pointed out. The topic of measurement, I think it becomes very important. ACD measurements, for all of you, understand that you don't take the IOL master and go for the epithelium. You have to look at the real anterior chamber. That's from endothelium to the crystalline lens. Type of phakic IOL is important. Avoid contact with the natural lens. Long-term healthy eye. Recommended minimum, I already touched this. And IOL positioning and vaulting is very important if you have a sulcus fixated. And the recommended vault is between 250 to 750 microns. We can discuss this in a minute. Lens size selection. Usually you do measurement, positioning, stability, and sizing is important. And what we all take is the white-to-white measurement. OCT, Scheimpflug, R-scan inside the Reinstein device is there for doing this. Individual variability, we all know that, and the measurement consistency is, of course, important. Complementary measurements are there. And you can see this here as a complementary measurement for the white-to-white importance for posterior chamber lens. You can see these here. I put other posterior chamber lens as well on this topic. And you can see here the optical diameter. They actually go in sizing. So myopia is here for hyperopia, and you can see the measurements. Let me take a couple, this last 3 minutes, ICL power calculation. This is from the company. You have a nice nomogram where you actually can work, put in your refraction, your ACD, and you get your sizing of the lens because this is based on the white-to-white measurement. I show you one case which demonstrates a problem. We did the same. We had an ICL implantation. The vault was 1,470 microns. The patient had actually good outcome, but he was complaining about photophobia, glare, and significant visual halos. And you see in green the vault of the lens. We exchanged the IOL to the actually lower diameter IOL, and we got a vault of 620. The patient was quite happy. Visual acuity was great. It was 20/25 with slightly amblyopic eye, but the patient 100% happy. So all the subjective photophobia went away. Optical phenomena significantly improved after the exchange. The patient is now very satisfied. Now, what do? We forget the low vault. 1 minute for this. I'm looking at the vault now. If I have just 20 to 30 microns of vault, I think that's enough because we have the central flow. We have not seen cataract formation with this, but this needs to be investigated. If we really need 250 as the lowest, or do we need 150? We don't know that. For the lenses which have the high vault, you can achieve optical phenomena, and you can also have an angle closure because we don't have an iridectomy, which is perfect for the ICL with a central hole. So there is a formula which we created with one of my fellows, actually 2 of my fellows. We're looking for this, select key parameters of ICL vault prediction by penalizing less relevant ones, reducing overfitting. You can access this formula on the internet, actually. This is a formula. Let me show what happens is when you put this in, they actually will predict the vault of your lens. If you have a sizing of 12.1, 12.6, 13.2, 13.7, you will see this outcome for post-optive vaulting. Most recently, our colleague from Salt Lake City, Mosifar, looked at the outcomes of the formulas, looked at regression model, trained in 115 eyes with our paper. Sorry, this is our lesser paper, which I just showed you. We trained a model of 115 eyes with 59 patients, and we had this formula developed. You find it in the internet. And the Mosifar paper is here, the ICL formula sizing, the accuracy of post-operative vault prediction and ICL sizing recommendations across all available nomograms. Includes everything what you find in the literature, by STAAR nomogram, optimized white-to-white, and then you can see all these different formulas, analyze 209 eyes, and particularly what he found is that the AI formulas, the artificial intelligence formulas, Russo, Kamija, Kang, and Chen, were actually showing a good outcome and that they can actually achieve maybe even better outcome for your prediction. That said, there is from Roberto Zaldivar's group and Roger Zaldivar, they also had the ICL Guru. This is a development taking place in South America at the moment, also looking at automatically calculation sizing through AI. So my conclusion, we have good outcomes with the eye for myopia. ICL power and sizing calculation is important. Too low, you can cause cataract formation. Too high, you have optical phenomena, risk for angle closure, glaucoma, and you may have to change. Best formulas for the moment is sizing calculation. In my practice, we use the STAAR nomogram, but we also add the LESO formula or other AI formulas in order to get our outcome, in order to become better. With this, I thank you very much for your attention and having me here.
Thank you, Thomas, for that wonderful talk. And I think vault is the most important criteria. Any questions to Thomas? We can have a couple of quick questions. Can we have the mic in the front row, please?
I think the question was, how do we compare? Well, there's the Nakamura. So there are actually 4 AI formulas. If you want to use them, you have to go in the internet and get the lens. I just showed you ours, which you can access through the internet but punch in your data and you get it there. This is a non-proved, technology, because basically what happens at the moment is we always send our calculation to STAAR. We calculate the lens, we get prediction, and that's the lens we usually look at, and we will order. But then we also go and take the lasso formula, take what we consider is the right thing. We're still under investigation how to do this in the future, but I would like to avoid the high vault and the low vault cases. These are very rare, I have to say. I would think that out of 100 eyes, I have maybe 2 cases of this. The rest is perfectly fine. And from 5 diopters, myopia and above, I always consider a phakic IOL to be my choice for refractive surgery. And we go down to 1 diopter if we have suspicious cornea. And sometimes patients just come for 3 diopters, as Robert Ang said, and they don't want to have any procedure on the cornea, and then we feel comfortable also to put it for 3 diopters. I think the world is changing at the moment. Phakic IOLs with the outcome we're seeing, the outcome is great, and so we will see what's going in the future. In general, we all have to work on this topic that we don't produce any complication with refractive surgery, otherwise patients are not following us. That's particularly in Europe. Still a lot of reluctancy against refractive surgery.
One question, please.
White to white. Yeah.
So,
and we can also use OCT. That's also, I think, included in the formula.
Can
Here's
you-
a microphone
Can you
if
give
you
the
want.
microphone there?
Thank you. Thank you, dear Professor. I have a question. Did you have any experience on patients with a high refractive error and low ACD, low than 2.8? Because a young patient with high refractive error, high myopic, and has only ACD not more than 2.8. It's around 2.5 and etc. And what's your suggestion such these cases for this case? Thank you.
That's a very difficult question for me, or let's say to handle these patients. The reason is we have these recommendations in Germany, which I wrote with a team. So I cannot go to 2.5 and say, I haven't read these articles.
Unfortunately.
So, but let me answer. So, but if I have a case, let's say 2.75, 2.7, then I have to speak, and that's an 8 diopter, and the cornea is 450, so there's no other chance, just to make it up. Then I have to speak with the patient, is that an outlier, and can we have an informed consent? I don't like to do it, but occasionally, if there is a huge, huge need for these patients, we may go. I know that in South America, in other countries in the world, they go for 2.5, but I cannot, I will not say this publicly because my recommendation 2.8 and 3 millimeters would be for the hyperobes. In the US, you saw they even have 3 millimeters now.
Thank you for your reply. It's the most common among Asian people, so I asked about this question. Thank you.
Flat anterior chamber and myopia.
Yeah.
Yeah.
Thank you.
one question, please.
So there's a need for a huge study for doing this. If 2.8 is the right anterior chamber depth.
Yeah, so normally for the sizing, we do white-to-white measurement in the operation theater under microscope, So since white-to-white measurement in the operating OTE is a little bit subjective, now do you suggest some other methods to corroborate or see or to find whether my measurement in the white-to-white is actually following the line, or some other measurements so we can correlate for the actual sizing? You may get my question?
Not 100%, but I think it always goes to the same, situation. How do we measure the sizing, and what do we do? Usually there is a correlation from the white-to-white measurement. Now we have to say, white-to-white measurement is not always the same. You take the white-to-white, take it 10 times in the same eye, you get different white-to-white.
That's right.
Because the prediction from where is white-to-white is in the machines. That's a machine detection. If you don't do it yourself, we did it in the beginning with calipers,
Yes. No.
just with calipers, but the calipers were then not to be as sharp as the Scheimpflug and so on. So I think that automatic devices are the way to go. The only thing they have to really measure correctly, you have to check. What I do is I always check my own measurement from my text, take a look personally and see if the white-to-white measurement was really the correct measurement. And nowadays we have now OCT, so you can have more measurements if you want. You can spend a lot of time. I think that a reliable, good measurement is the most important thing.
Thank you.
I just want to add something, because if you have shallow chambers, as you talked about, I think it's always good to do a gonioscopy in these patients. If you think your angles are widely open, your 2.6 can become 2.8 easily, you can write up there. And if you have hyperopic patients, what we do at our center, we need 3. So if you have 2.8, we still go ahead and do a PI. Anyway, we have to do a PI. And we tell the patient if your chamber goes beyond, and we realize that in hyperopes, we do PIs, 2 PIs, following after a few months, chamber tend to go a little deeper as compared to the myopes. And I think a gonioscopy is a good way, and you can be safe if you tell the patient, yeah, this your angles are open, when still we're putting at 2.8. So I think that's what you should go about. And gonioscopy, I think, is very important in this one.
I think, thanks, Thomas, for that wonderful discussion. You want to add something?
Let me add this. I unfortunately have to leave you. I would really love to be here, but your program put me to give 2 more talks in another room, so I'm sorry. Happy to be here. This was a nice symposium. Thank you.
Thanks, Thomas, for that wonderful talk. Thank you very much. So now we have Dr. Sanjay Chaudhary. He'll be talking on pearls to optimize patient outcome with the EVO ICL. I think Dr. Sanjay Chaudhary needs no introduction, and he's one of the largest ICL users in India. All to you, Dr. Chaudhary.
Thank you, Dr. Sonugal, for that kind introduction. When I was looking at what I think I should talk about in this session, I realized that there's a lot of confusion regarding the sizing. And sizing is the primary area of problem because there are so many options. So probably a review of how we can get more and more accurate on the sizing is and understand the fundamentals of how we go about it. So the first problem, we are all told that we have to measure a white to white. So this is a white to white, and on the left side is the sizing. The OCOS system, which shows that from this size to this size you use 12.1, 12.6, 13.2, and 13.7. Now, the problem is from 11.14 size to 11.15 size, 0.01. There's a sudden jump of size. And this is more relevant in the small eyes where the jump is very steep from one side to the other side. In the bigger eyes, it is less of a problem. So we'll see what we can do about this. And then if you notice another thing, it was just an observation that on this chart, if you look at the last figure, 11.4, in the white to white, and you add 1, it becomes, 11.1, you add 1, it becomes 12.1. 11.6, it becomes 12.6. 12.2 becomes 13.2, and 12.7 becomes 13.7. It's just an observation that actually you're adding 1 millimeter to the maximum value of that range. Just an observation. Maybe that observation helps in a future discussion. Okay, now white to white. It is the main parameter for ICL sizing today. And it also happens to be the most variable parameter. Like Thomas just said, you do white to white 10 times, then you get different results. And that is actually a fact. Not only on one machine, but if you have different modalities, you will have different results on all the modalities. For example, for years, we have been using this concept. that when you do a digital caliper, if the size is 11.7, and on pentacam, it usually shows up at 11.9, and in optical biometers, it shows up as 12.2. That's a huge difference. Now, which reading will you take? That's the dilemma with us. That with such a long range, what reading would you take? And you know what? That's the biggest surprise. And we have accepted that surprise, is that all the above readings are correct. All the above readings are correct. So that's the bigger confusion. And pentacam is close to the digital caliper and is more by 0.2, and optical biometer is about 0.4 more than the manual digital correction. But this is, we have been made to understand that all these readings are similar, and you can just go ahead with the same sized ICL. The other dilemma which we have been facing is what is actually a white to white. Look at this diagram on the left. Here is one white to white on the top, which is from the true area where the sclera starts. At the bottom is one white to white, which you can call is clear to clear. And in the middle is another white to white called mid to mid. When we started off, we said the clear white to white is what is called the horizontal visible iris diameter. And this is what we are supposed to use. Then it said, no, the real one is the outer one, but outer one becomes too big. That means outer one is the true white to white, and it becomes too big, so you use the mid to mid, and that is the best way to go. And now if you talk to 10 people, all of them would be promoting a different white to white. Even as of today, nobody is exactly sure which is the right white to white. And this is where an OCT comes to our rescue now, the AIOC. It has taken away that manual element, and the ray tracing systems or other ways of capturing has given us some idea of where we actually stand. Let's see how. So, yesterday when I was giving my talk on ICL, a lot of people asked me, sir, why don't you just explain to us about these OCTs, AIOCs, and its sizing? Because all these formulas are using spur to spur, angle to angle, white to white. And we really don't know how to go about it. So will you just give us the anatomy of an AIOC? I thought probably this slide might be useful. So I just put it in yesterday. So let's see, just a basic understanding. The cornea, epithelium, stroma, endothelium, anyway, not much of interest here. Conjunctiva there, sclera there, and trabecular meshwork. This is of interest. So the trabecular meshwork, if you look at it here, it is attached to one point here, which is the scleral spur, and it finishes off here where there's a Schwalbe's line. Right? OCT trabecular meshwork zone is very clearly defined. So this is the limbus. So in the limbus, if you're doing your surgeries, you have this conjunctival area also, you have the scleral area also, you have the trabecular meshwork area also. But when you're doing your cataract surgeries, you are not piercing the trabecular meshwork. Why? Because you give a little incision here, which is 0.3 millimeters, straight incision, and then you take it parallel to the iris. So you come out in front of the iris. Right? Now, this is the scleral spur, a very important landmark for us when we are doing the ICLs. And the ciliary body, the interior chamber, and the angle. These two are very important landmarks for us. This is the angle, and this angle of 30 degree is an open angle. So you have to learn to recognize the angle, you have to learn to recognize the scleral spur. If you have to really move on to get a right sizing and use the AIOC in the best possible way. Okay, then let's go. Now this is the AIOC. Now, I'll spend a little time, but this is the crux of this talk. This AIOC says, look down here, in the violet zone. This says 12. I'll take another 3-4 minutes. Just explain this slide. This says 12. Now, if you put 12 here, you find that this V zone, let me show this here. You see this is the cornea, which is fitting into the sclera, and there is a V zone. Now, this point of the V is where it is all sclera, and this is the true white to white. This part of the V, which is more or less no sclera now, is clear to clear, and the mid is between these, right? So, if I put the marker on this V here and this V here, this is the white to white. What AIOC is taking, and it's taken here as 12, so it's put here as 12 millimeters. Now the AIOC automatically takes the spur and the angle-to-angle calculations on its own. So spur is in yellow, and this is spur in yellow, and this is 11.59. More or less the same as the white to white. White to white often is just a 0.1 millimeter more than the spur to spur. Look at angle to angle, 11.56, 11.86, sorry. Now, angle will always be a little more than the spur because the eye is going in like this. By default, it has to be a little more, approximately 0.2 more. If you understand these dynamics, the white to white where it actually is, because when the rays of light are coming out of the eye, the area which is, the rays are totally blocked. That is the white to white. White to white, angle to angle, spur to spur. If you have these fundamentals right, look at this option. Another option says that in this capturing, I could capture spur to spur. Spur to spur comes out very easily in all AIOCs, but it is not a must that angle to angle comes out in all. Angle to angle capturing is sometimes missed in almost 30% of the capturing. So probably your spur to spur and angle to angle and white to white, since the differences are not major, and the reproducible matrix is spur to spur, then all formulas which are related to spur for calculations would probably do well. But if you look at this, white to white is a very variable metric, very variable. Technically, I would say it is fairly useless. When acquired by different methods like calipers, pentacam, and optical biometers, on AIOC, it is a shade larger than SSD. SSD is spur to spur, right? Sulcus to sulcus would have been an ideal parameter. It is captured by the high-frequency ultrasound. It is highly user-dependent. It loses its importance because of its variability, because there's an individual factor to it, patient discomfort, and a long capturing time. Now, I recently went to Korea, visited some South Korean ophthalmologists. One ophthalmologist only runs an ICL clinic, ICL center. He doesn't do anything else, just does ICL. We're talking to him, he said, sir, we have stopped using the ultrasound. We are totally on AIOC. And spur to spur is the most reproducible and a consistent metric. And angle to angle is a shade more, but not as reproducible a metric as compared to SSD. Can be difficult to calculate in narrow angle situations. However, if you can calculate it as a routine, it is the best metric. Why? Because the angle to angle very clearly corresponds to the sulcus to sulcus, because they are both uveal tissue, both based on the root of the iris. One is in front of the root of the iris, one is at the back of the root of the iris. So if you have to say which will match most the sulcus to sulcus, it should be angle to angle. Both are you able to choose at the root of the iris. I'm just talking about a very fundamental thing, and probably I'll just finish it off. Crystalline lens rise is another important metric. This is typically angle to angle line and the front part of the lens. So if you look at this, lens rise, here it is seen as lens vault, is minus 0.25 millimeters. That means 250 microns. So it is typical, this red line, angle to angle, and this front part of the lens. And this difference is 250 microns. It is minus because it is below the line. If it is beyond the line, it would become plus. Understanding these matrix, here is what I picked up from one of the journals, JCRS. And they said that 11.56 is what is from this part of the V to this part of the V. So the journals are also talking about what is actually a true white to white. So I would recommend, even now when you're using your calipers, use the real outer white to white. The time has gone when you're using clear to clear. The time has gone when you're using mid to mid. The time has come when you're going to use outside to outside, because that is the one which is metric, which is going to match your OCT white to white.
So can I request you to please summarize?
Yeah, sure. Half a minute?
Yeah.
And I'll just finish it, right? So ICL position is independent of crystalline lens rise. A very important statement. That means the ICL is going to come in the sulcus. It is going to take its own curve or vault. It has got nothing to do with the crystalline lens. Crystalline lens is just lying below. But the vault becomes relevant because if the clear lens rise is high, for the same ICL position, the vault will be less. If the crystalline lens rise is low, for the same IOL position, the vault will be high. And whenever you're using a formula, it is more dependent on the sizing and the vault. It is comparatively less dependent on crystalline lens rise. So I think there's a formula dilemma. 90% of the ICL surgeons are still using the OCOS formula with the white to white as a standard. I would suggest that it is time we moved on to the next level and base all our findings on AIOC. And another thing which I found very useful, the last point I want to show to you, that even though you follow the NK formula, KS formula, or the lasso formula, they're just giving you ready AI answers. But sometimes those answers may not be correct, and you have to use your logic. And if you have to use your logic, one simple way would be calculate a spur to spur distance, add 1 to it, and that value we have used in a number of cases where there was a doubt really works out to be the right value. But so it is that surgeons are not robots. They still have to use their intelligence and sometimes think out of the box to get the right vault. Thank you so much.
Thank you, Dr. Sanjay Chaudhary. So I think it's not the artificial intelligence, it's the human intelligence which actually works.
True. So I think AIOC these days are with most of the doctors, because OCT is with everybody. Probably 90% of the practices have OTCs now, OCTs now. So all those have AIOCs.
Meanwhile, I'll request Dr. Sudarshan Khokar. Sir, please, because you have another talk. So I'm sorry to interrupt. Yeah. You can continue. Meanwhile, you just
so AIOC is just a matter of getting into it. It's there with all the practitioners now. Mm-hmm. Once you start getting used to that idea of doing the spur to spurs and basing your calculation on that, and then see what OS, the STAAR formulas give you, and whether you agree with that or not. Most of the times, you really come up with the right size, different to what was recommended by the standard OCOS formula. Thank you.
Thank you, sir. So now we have none other than Professor Dr. Kokar, and I think he's one of the most experienced ICL surgeons in India, and he'll enrich us with his vast experience from cornea to lens, the safety and efficacy of ICL. All to you, sir.
Yep. Thank you, Son. Thanks to the STAAR team to having me on board. I promised them that I should come at the end so that I see what people have already presented, so it becomes easy for me to step onto them and climb up. Okay, so when you start surgery, when we started surgeries a few years back, it was only cornea, and we're doing the PRKs, and PRKs, and by the way, they're coming back, PRKs coming back. Then we started having LASIK, E-LASIK, C-LASIK, D-LASIK, whatever. Then you got smiles. But the thing was that you're taking the tissue away from the cornea, and which eye can you predict will go into ectasia? Anybody can predict that? Nobody. People can have PRK with ectasia. You can have any corneal surgery, we can land up into ectasia. So that element of doubt is always there. So why can't you go for something which is as good as a phakic lens in which you're adding? So you're not taking away, you're adding. So when you add, people always they want more, I know. If you get more interest, of course, you'll put more money into that one. So you want more. So I think the same holds true here also. Okay, so what I'm going to talk about is, okay, that's a disclosure. See, to start with, there's no risk which is too low for a refractive surgery patients. These are individuals with the glasses, they are 20/20 or 6x6 vision, leading their life absolutely fine till they get some peer pressure, or they're applying for some job in which they need to get rid of glasses. Which again, I don't think is a good thing to remove the glasses for the job, because you can again have a refractive error later and can land up in more trouble. So till then, they are absolutely normal individual living their life. I still see about 60% of people wearing their glasses. I don't know why they didn't get their cornea cut off. So refractive error is actually going on the rise, and the myopia is on the rise. If you see that 36% of the distant disability is because of refractive error, and by 2050, it's anticipated that 5 billion of the population is going to be having refractive error, and 10 billion will be high myopes. When I say high myopes, I mean it might be out of the range of the corneal refractive surgery. So this is why this symposia becomes very important. Everybody has to learn how to do ICLs. And a normal average cataract surgeon can actually go and pick it up without any problems. Okay, so here we go. So spectacles you can give contact lenses in the refractive surgery. See, in the 19th century, world wanted wisdom, and they became wise, right? They were reading a lot of literature. Everybody was onto all these big literary guys in 19th century. Then came 20th century. We had the little left angle. People wanted to fight, wanted freedom, and they got freedom. Most of the places, when they broke into smaller pieces, it was happening in 20th century. And now the 21st century wants the world to see the world without glasses. See, all these patients which used to come to me 20 years back, 30 years back for refractive, and which they come now. Now these kids are so aggressive, they want to get surgery immediately. When they come, they say, just operate. Earlier, we used to evaluate, talk back, go back to the family, come back if you're ready or not. And we were also skeptical because the machine was not up to the mark and the lenses are not good. Like people talk about PR lenses falling into the vitreous. But now I think we have reached a place where it's very safe. Even my kid, if I have to do, I'll do it for him. Earlier, we used to think twice, actually, right? Even the doctors. In fact, I put ICLs in the last 15 days in about 5 to 6 doctors who had come for their own ICL than I am. They're surgeons, they are anesthesia guys, and they're happy about it. So they want independence from glasses. So we know all the modalities available to us, and this is, if you see the protocol here, according to FDA, this is the only surgery ICL which covers the broadest range from spherical plus and minus both with a high cylinder. So as I say, all the refractive procedure being a corneal or otherwise, it has to be a stable myopia. And cornea, there's a problem. You have to have a residual bed thickness, and if the cornea is too steep or too flat, again, you can't go for the corneal procedure. And ectasia is always a problem, and you can have incomplete flaps, you can have vertical gas breakthrough. There's so many complications which can happen in the cornea which are not at all there in the phakic lenses. So what if the patient does not fall in the criteria? If the patient is a hyperope patient and patient has myopia more than 8 or high cylinder? So these were the rejects from the corneal surgery which was coming for ICLs, but that's not true anymore. In my clinic, even a 1.5 diopter minus is offered ICL. And you'll be surprised how many of them are actually picking up, okay, for this surgery. So implantable is the same thing. The criteria are all the same. Lens power has to be stable. If it's varying, there's no point to put in the implants because you'll have to go touch up later on. The only thing which has come is you have to look at the anterior chamber depth, and we do a gonioscopy in all the patients, manual gonioscopy, and we have the anterior, and we use the anterior also, and we can actually find the angle which Sanjay showed at 30 degrees, so we can pick up in all images, and you can follow these patients up, and that way your 2.6 might be 2. You can make 6 into 8 easily, but 2.5, it's a little skeptical there. Endothelial count is important because especially for the beginners, if you're not very good at it and you might cause an issue there, you're viscoelastic, the pressure goes up. If your specular count is good, you can go ahead and do all these patients without any problems. So there are lots of phakic lenses, but there are only 2 which are FDA approved. One is the ICL, and another was the Verices, which nobody is using now. So there are lots of players which have come with the different materials. Those materials might be good as an IOL. When you do a cataract surgery and put an implant in the bag, that's fair enough. But when it comes to a lens which has to respect the anterior capsule as well as the corneal endothelium, I think there's no material which is better than Colemar, and we've been using for the last 30 years. And incidentally, when we operated few patients now for the cataract, we realized when you took these lenses out, there was not even a speck of any dust on that. There's nothing, no addition of anything, and they were absolutely clear. So the sizing, as everybody said, is good. What I say is you do a refraction yourself in all these patients. If you have an error in the refractive error, so garbage in will be garbage out. If you put a wrong refractive error, your result is never going to change. Okay, so your refraction is very important. Sizing, I think everybody's talked about. I'm going to just skip the sizing. This is a article in which Pope et al., which they published. They measured about ICL sizing from angle to angle, cell to cell. It's an old article. The only flaw was they used a 50 megahertz probe for the UBM. And they have to take 3 pictures and make a collage. So it already had an error in that. So I don't believe in that. These are the 4 sizes available. So you have to make sure that the patient fits into this one. Whenever I have to err on the size, I always err on a little larger size. I want a little higher vault than a little lower vault. So why 4 sizes? Because if you see this study, in this study, there were thousands of patients taken from the normal age from, say, 20 till 50, 60 years, male, female, and they found out the results that majority of the patients actually are fitting into the criteria. About 90+ patients are fitting into this criteria, so that's why the lenses are there. Even if you change the size of the lenses to say 11.25, 11.75, still variation will be there because it's not going to fit. It's not like buying a ready-made shirt versus the one which you get tailored made. So there's going to be always a variation, but because of the material and the such soft haptics, this problem of about 1 millimeter can easily be compensated in this one because these haptics are actually malleable and they can adjust in the periphery very well. Okay, so people have discussed all the sizing. I'm going to skip the video surgery. I think everybody's a good surgeon. So why should I use a phakic lens on a corneal surgery? Because phakic lens can be performed for any routine person. You don't need to have a femto machine in which you can't do a fumigation. You have to switch over. Your routine cataract setup is good enough for you. You take caliper, you measure anterior chamber depth. You can go ahead and get your surgery started the next day. You don't have to worry for all these things. Like even the surface problems are there, you don't have any problems in that one. It's a reversible thing. There are lots of patients who get this surgery. We had a patient in which did a LASIK, and somehow after the surgery, his vision was 6.5. But somehow he got into his head that this is not good for me. He wants it to be replaced, reversed. You can't do that because the tissue is already lost, right? Here, if you have situation, you can always go ahead and take it out. Visual recovery, all these studies say that even if the smile, as last thing you talk about, this has the best vision, which is in 6 months post-op, they might be similar, but in the first 6 months, it's like that. The safety index, there's no doubt about that, this is the best. Even an average cataract surgeon can actually go and do this. For smile and all those, you have to be a lamellar surgeon. You should know where the planes are. There's a little learning curve there that's not here. So these all studies just say the quality vision, of course, is par excellence. It negates all the ectasia association. There's no study in the literature which say that you've done an ICL and you got an ectasia. Okay? Even in the patient in which you have a stable keratoconus, you done a C3R, and for last 2 years it has not progressed. We put ICLs and we followed them up. There was no change because you're not actually screwing up with the cornea per se. When you cut the cornea, it reacts. The metalloproteinases, you don't know how you're going to behave with that. So any of these, it's apoptosis. So anything can trigger on the cornea. So that's why you have to be very careful about the corneal surgery. Saying that, we got 2 suits. We do lots of those ones. But still, if the patient wants refractive, we always go for the phakic lenses. So phakic lenses, pre-op, okay now, when these patients go old and you want to do a cataract surgery on this one, we are getting the patient which you done about 20, 25 years back, and these myopes will have cataract little earlier, nuclear sclerosis. So I do the biometry the day I want to operate, and whatever my value is, I go ahead and do it because the column is such thin that it does not cause a change in the deviation or the velocity of the sound which is going through. So we published a paper, this was 10 years back, in which we did a preoperative measurement of the exit length. We followed this patient for 3, 4, 5 years, and we realized it doesn't make a difference actually. Okay? So keratometry doesn't change because the incision at 2.2. Whatever's happened at the surgery, by the time the cataract comes about 15, 20 years back, it's already stabilized. Your keratometry, your exit length, whatever you get the day of the surgery is the true value for you. You don't have to go for a D1 value, preoperative, corneal refractive, what was the surgery done earlier. Nobody keeps the data these days. So this is a safest method. Now, the other paper we published was on the stereo acuity outcome. How many people have managed patients, say, minus 16, minus 18? Can I see a raise of hands? Okay, so 1, 2, 3. So on these patients, you can't do a corneal surgery because if you take the cornea will be ectasia only. So we did a study in all these 15 plus ones, and we realized all these patients who could never had a stereo acuity now started having a gross stereo acuity and the depth perception. So that means they can go and watch the Avatar movie without any problem, which they can't do because the corneal surgery is not going to help them. So this is another thing which can add, especially these patients are stereo blind because of minus 16, minus 7, minus 18. But after the ICL, because of the magnification factor, they could appreciate the depth also. Okay, this example, I think I can skip because I think Ramurthy is here and the time is also up. So it's not that it's a reject of refractive corneal surgery that you have to take up. You can take up patient otherwise also and you can offer them. And I'm telling you all the patients are going to be happy. Just the last slide. The new modifications come, I think, which is talked about. So I choose ICL in a practice where it's safe, it's predictable, there's no loss of contrast at all. You do a PRK, anything, because once you have an interface, you're going to have a contrast loss. No regression in these one, and this is reversible. The red zone is the cost factor, which I think the STAAR people should reduce the cost, which they have to discuss. Sizing is a limitation, but you have to work on the sizing, and it's an intraocular surgery. But now the kids are so aggressive, they don't mind actually intraocular surgery. So they're happier in the visual outcome. The next day is 20/20. We operate both the eyes on the same day. I use 2 hours, I do one patient, and after 2 hours, I do the other eye in the other OR with the other machine after washing. So it's like 2 different OTs for the same patient on the same day. And with that, I'll close. Thank you very much.
Thank you, Dr. Khokar sir, for that wonderful talk. Any quick question to Dr. Sudarshan Khokar sir?
Sure, please.
Yeah. Can we have the mic, please? Can we have the mic?
I think it's loud enough.
Yeah.
Okay. Right, so if I have a patient which was 618 pre-op BCVA and I put an ICL in this patient, the vision actually comes 6.9 later on. And the reason is that you have got magnification. If you see the magnification factor, when you see the logmar, when you jump from one light to another, it's 1 logmar, which is 1.3396582571. So every time you change it, 25% magnification happens when you add the nodal point, which happens only with ICLs. So even the amblyoptic eyes, the vision improves. And we realized that 618 patients are 6.9, and with pinhole, they come into 6 partial. Then we went and checked the literature. They said if you have the magnification, if the magnification is given 25%, you get 1 line. So in the ET PRS chart, each line has a 1 logmar jump. So we can get 2 lines or 3 lines depending on the patient. But if it's a grossly organic lesions on the macula, it's not going to change. We do lots of myopics which are 636, but they have lesions in the retina on the macula. So we do it because they don't wear the big glasses. But amblyoptic patients do get some vision back. Arun? Oh, yeah, these were gross stereo acuities, but still close to 150, between 100 to 3. So we had about a 7 to 8 patient in this group. It's not a big study, but it's there. On the other hand, if you've done in a eyes in which there's not a high power, I think it crosses, it's like a high definition TV they're watching, I think.
Thank you, sir.
Is that good? Thank you. Sorry? But then, if the eye is small, the lens will not go in. I think, can you make smaller lenses for sir? I mean, so the problem is the sizing. So all these ones with the abnormalities in the eye, small eye, colobomas, this is not meant for those people actually. Right, sir? Sir is a pediatric ophthalmologist, so that's why he's talking about the Mycon. It doesn't work there, sir. No. Sorry.
Thank you, sir. Thank you. So now we have Professor Dr. Ramamurthy, and he'll be talking on mastering pre-op measurements and interpretation, predictable ICL outcomes. All to you, sir.
Thank you so much, Sonu, and I have no financial disclosure relevant to this presentation. I think these are the principal things that we look at in preoperative measurement, that is refraction, objective and subjective, acceptance at 12 millimeters vertex distance, the anterior chamber depth, which is to be from the corneal endothelium, the white-to-white measurement, and the K reading and topography. It's because it is this white-to-white measurement, K reading, anterior chamber depth, which has a significant impact as far as the sizing of the lens is concerned. Needless to say, the other aspects of the anterior segment and the posterior segment, especially in the highly myopic eyes, have to be checked very well. And a very accurate refraction where the subjective acceptance of the patient is most important rather than the objective refraction. And ideally, these patients have to be off contact lenses for a week before surgery if it's soft lenses, 3 weeks if it's a semi-soft or hard lens. Obviously, we're not doing anything to the cornea, but still I would like to follow this dictum because the quality of the refraction as well as the accuracy of refraction could be influenced, especially if it's a long-time contact lens wearer with some amount of warpage. Accurate estimation of the cylinders and torics is extremely important. And one other thing I do is that in case there is a 0.5 to 0.75 diopters of with the rule astigmatism, which many of these young patients have, I make a superior incision because I usually do a 3 millimeter incision. Just in case for cost reason the patient is not interested. Almost 70-75% of the ICLs I use a toric. But just in case the patient has just about 0.5 diopters of with the rule astigmatism, I do a superior incision. I think there will be a video also on that. And this is the most important factor in the sense that endothelium to the anterior capsule, it has to be at least 2.8 millimeters. But this was a dogma that was created in the minds of people. Initially, STAAR used to say it should be nothing less than 3 millimeters, though we went ahead and used 2.8 millimeter. But today we are trying to stretch the limits. I think Kimiya Shimizu has come up with the concept that he has done eyes up to 2.5 millimeter. Maybe it's not for the beginners, but we ourselves have started doing, after looking at the lens size and various other factors, up to 2.6 millimeters, we are doing a control study to detect whether we can stretch the limits in these extremes of eyes. Maybe we can discuss about it a little later. And we need an internal ACD. One of the things you need to remember is that whether it's Pentacam or many of your instruments have as a default setting from the epithelium to the anterior capsule. So you have to make sure that either you detect the epithelial, the stromal thickness, or you dial it in such a way that it measures from the endothelial aspect. And this is something that needs to be done in every case. And one very important thing that needs to be remembered is that higher the power, whether it is minus powered lenses or plus powered lenses, these are the ones which are thicker in the periphery. Because this is where you are sort of, the patient begs you, you're also somewhat tempted to bend the rules in the sense that if it's a minus 18 diopters, obviously you don't want to do a clear lens exchange on that patient, not fit for laser vision correction, and he or she is very keen on a phakic intraocular lens, but has a 2.6 millimeter. But then these are the eyes where you have to strictly adhere to the criteria. But having a center of flow or a PA is not going to help you as far as bending the rules is concerned, because there is a crowding of the anterior chamber and crowding of the angles which you are bothered about. So once you have, please remember, it's not just sizing alone that matters. The AC depth and the keratometry is also important. When you supply the data to the company, they use all this data to determine the sizing the lens. So getting the AC depth as well as the keratometry is as important as getting an accurate white to white. And again, as a thumb rule, the size of the lens is about 1 millimeter more than white to white if the ACD is in the range of 3 to 3.5 millimeter, which is very often the case. If it is less than 3 millimeters, it's one step less, that's about 0.5 millimeters less. And if it is more than 3.5 millimeters, the sizing of the lens is slightly more. So obviously it stands to reason. Obviously, if you have a smaller eye with a shallow AC, you would put a smaller lens, and vice versa if it's a larger eye with a deep AC. So as far as this was the point I was trying to make, just in case you have a very high myope or even a very high eye probe where it's a plano-concave lens, is the periphery which gets thickened out, and these are the cases where you tend to stick to the dictum of about 2.8 millimeters, and it's the eyes in the range of about -6, -7 diopters, where in case you want to do phakic intraocular lens because of cornea being inappropriate, maybe you could consider 2.6, 2.7 millimeters, but large studies have to bear it out that this is the right way to go. I think the standard of care as far as measuring white to white is concerned is still the digital calipers. This has to be done in the OR with the patient anesthetized with a speculum in place under the operating microscope. That's when you get the most accurate readings. You can do with the OpScan, Pentacam, Topolizer, etc. But let me just come to this slide. Basically, these are the various measurements that are possible with different machines. Obviously, it will stand to reason that because the lens goes into the sulcus, a sulcus measurement would be most appropriate. It is possible with the UBM, but most phakic intraocular lens manufacturers, as well as the ICL, as of now, is based upon most the white-to-white measurements rather than the UBM measurements. With most UBMs, the problem is that the sulcus itself is an ill-defined area. And if you have the same person measuring in one eye of the same patient at 2 different times, sometimes you get 2 different variable readings. So it's important that we stick, as far as now, we stick to the white to white, though artificial intelligence based formula, etc. is coming into vogue as far as sizing of these lenses are concerned. And as I already mentioned, digital calipers is the gold standard. And what you find over here is that Pentacam and Topolizer seems to line up pretty closely to them. But if it is anything based upon laser interferometry principles, they are not measuring white to white, but they are measuring sclera to sclera. And that's the reason that the measurements that you get with them is slightly higher. And that's you have to account for that in case you are using like a IOL master, and it's not the right instrument to be used for white to white measurement in these cases. And as I already mentioned, phakic IOL size is about 1 to 1.25 millimeters more than white to white. In case you are going by the sulcus to sulcus measurement, it's about 0.35 millimeters. This is as far as eyes of standard configuration is concerned. You get surprises of the sizing only because not all eyes are the same, and it's several other factors like the lens rise also plays an important role in this. And using the calipers, I think all of us can afford this. The calipers has to be well calibrated, and I already mentioned it has to be done under the microscope. And please understand that the white to white, the limbus is not a single line, but it's obviously a zone. And essentially what you have to measure is from the mid limbus to the mid limbus. Leave the blue alone, leave the white alone, but carefully under the microscope, go to the central area and measure from the mid limbus to the mid limbus to get the most accurate measurements. And this is also something I mentioned that all of our eyes follow the principles of enantiomorphism in the sense that the white to white of the 2 eyes should correspond to each other. Just in case the white to white of one eye is very different from the other eye, it has to be suspect. And we always do it with the OpScan, with the vernier calipers, digital calipers, as well as with the Topolizer. The reason being that in case and most often we go with the Topolizer measurement because the instrumental measurements is always better to rely on. But if there is a pigment or a blood vessel right at the limbus at the 3 o'clock or 9 o'clock meridian, the instrument might include that. And that's the reason that you want to measure with the calipers also and make sure that all these in both the eyes together line up. And especially in a keratoconus eye, because you might have a central steepening over here, and if you essentially go by this AC depth and size your lens, then there could be excessive crowding. That's the reason when we use a toric ICLs in these situations, we always bring down the measurement by 0.5 millimeters. It's also been said that you can take peripheral AC depth measurements also and incorporate them, but algorithms to measure ICL sizing based upon peripheral AC depth is not available. So it's a good idea, especially if there's a significant central steepening. And nowadays, usage of toric ICLs in case of keratoconus is on label. It's not off label any longer, especially it's a well-centered keratoconus. And these patients do benefit, so you do well to bear this. And finally, it's a good idea to have a look at the scotopic pupillary size. And now with the EVO available, which is of a larger optical diameter, these patients seem to do well. But just in case it's a young myope with a very large scotopic pupil area size, at least you must forewarn that patient that he or she is going to may suffer from halogen glare subsequent to the implantation of these lenses when the pupils enlarge beyond the size of the optics of the lens that you are implanting. I think the success of the phakic intraocular lens surgery depends almost entirely upon accurate and precise measurement of the preoperative parameters. I'm sure the previous speakers would have made excellent presentations. The surgery itself is quite doable for any reasonable anterior segment surgeon, even though you operate within the confines of 3 millimeters between the anterior capsule and the endothelium, and not 8 millimeters as in the case of phacoemulsification. But then it's doable. But then to get optimal results, it's not just the refraction alone, but the entire analysis of the anterior segment that's extremely important. Thank you so much for your kind attention.
Thank you, sir. So to summarize, you actually mean to say that the ICL surgery is now available for the entire gamut of range of myopia, starting from low myopia to any level of high myopia for keratoconus also. And then any of the people can practice ICL surgeries, and no fancy gadgets are actually required, and no fancy tools are actually required for ICL or phakic IOL implantation.
I think our numbers are also constantly dropping. You know, when I started refractive LASIK 1997, I said -30, no problem, I'll do LASIK on you. Simply because we didn't understand there was nothing like keratoconus that was known to us. Slowly dropped down to -12. Now anything beyond -7 or 8 diopters, anything beyond 3 diopters of hyperopia or astigmatism is phakic intraocular lens which we go for. And again, if the patient, I always believe that laser vision correction has a lifetime. In the sense that even though you have achieved emmetropia initially, over a period of 5 to 10 years, there's some amount of regression. But phakic intraocular lenses, what you get till the onset of presbyopia, cataract, that's what the patient is left behind with. So the patient with a -6 diopters, extremely insistent, looking for absolutely crystal clear vision at the end of surgery, and doesn't want any compromise in the quality of vision, I would always tell him or her that this option might be better suited for you. And there are quite a few takers for that.
True, very true. Any quick question for Dr. Ramamurthy? We can have one or two questions as we are ending the session. Dr. Bharti, any quick comment or quick advice to the house for the phakic lenses?
I think there are two take-home messages. One is that a fancy gadget like excimer laser machine or a femtosecond laser machine is no more a necessity for a refractive surgeon. Anyone who can do a good refractive.
But you have to buy the lens.
So buy the lens and you are making money out of buying the lens. You are not making immediate money by spending 5 crores, my dear. So that is one thing, because there is a, kind of restriction on how much you can spend and make. And the second thing is that variety of a whole range of spectrum of all kind of refractive errors which you can, kind of do with the excimer laser or a femtosecond laser. Majority of them you can correct with the phakic IOL also. So I think that the take-home message is that if there is any, reservation in your mind as to whether you can do a intraocular surgery or not, I think that reservation should be over. And, there's a big competition between the two, procedures now, I think.
Thank you, sir. Vardhaman, do you like to add a quick point?
Yeah, right. So I think, of course, we have spoken about all the points. And again, reiterating the same thing is actually your sizing is the most important thing. And you have to always make sure that probably you have 2 or 3, if possible, gadgets to collaborate your findings. And usually the sizing is very predictable. It is uncommon to have possibility of exchanges. Number 2, of course, is that just make sure that whenever you are actually analyzing the patient, ensure that the patient is analyzed in terms of cornea well whenever you are taking a call, because I see so many patients who have been actually told to do laser when they are actually having significant skewing, significant asymmetry, and can lead to ectasia. So these are the patients that a lot of people miss, and they should have undergone phakic lenses, but because the surgeons are not probably doing phakic lenses, they do LASIK on them. That should not be done. And it's a very simple procedure to perform. Anyone who does a good phacosurgery, I think it is a cakewalk for sure. And definitely the numbers are dropping in terms of diopters, as sir has said. So right from -2 to -18, I think you have a complete range in which you can do it. And it has also become one of the primary options now. There are patients who come to me now, and even if they have -4, they do ask for ICL many times. Yeah.
And there are...
Yeah, please.
In cases of this post-cataract, sometimes if you're doing a lot of ICLs, then you're getting the cataracts also. Some modifications in the biometric calculations, or even
No.
if you do the Indian ICLs.
So
There
actually,
are no modifications needed because the ICL thickness in the center is just about 50 microns. And whether you're doing an immersion A scan or whether you're using a optical biometer, it does not alter the axial length readings in any way. And since the cornea is untouched, you can just go ahead with the use your usual formula. And I think so. No, it won't make any difference. It doesn't.
No modification.
and it's very easy to explant. I mean, through the same 3 millimeter incision, the ICL can be explanted and the cataract surgery can be proceeded as required. So in my practice, I would offer the patients all the 4 ranges, PRK, LASIK, SMILE and phakic lenses, and then let them choose their own, and the advantages and disadvantages is given to the patient. And I think almost 30% of the practice has now become for phakic lenses. And with the addition of EVA Viva, I think more is yet to come when it touches the presbyopic collections. I think.
Even when we run the toric ICLs, if we get some surprise in the toricity, can we rotate and all that? Can we do
So you just need to go and check the vault. If these patients have a low vault, you need to, you can go one step ahead, one size ahead. If it is, you go re-rotate. If it still rotates, you need to go one size up. So actually, vault is the major predictor for toric rotation.
The other factor you need to keep in mind is what is the spherical equivalent of the residual refractive error? Because if you rotate the lens, you are not introducing any power, you are just redistributing the power. So if you have -1 diopter spherical with +2 diopters of cylinder, rotation of the lens will help. But if we just have -1.5 diopter cylinder left over or +2 diopters of sphere left over, rotation is not going to make any difference. In that case, the wrong power has been put in, a lens exchange may be necessary. Rotation, so you have to make sure that the spherical equivalent is 0. And in that case, if you send the data across to STAAR, they themselves will tell you how exactly to position this lens.
So one thing is that the lenses are customized nowadays. So they're like, you put it a 180 because they are all customized lenses, no?
Some companies do that, but then, because of the very large inventory that's required and the speed of delivery, these people, they deliver the lenses, but the amount of rotation that's needed is less than 22 degrees. And that's quite acceptable. It works quite well.
So I think thank you very much, and thanks for attending this STAAR Symposia, and thanks to the chair, co-chair, and the speakers. Thank you very much. And